Hello, my name is Jamie Stearns, and I'm Clinical Nurse Educator on the Medical Palliative Unit at the PCH. This presentation will review the essentials of basic rhythms as we implement satellite telemetry monitoring at PCH. The implementation of satellite telemetry monitoring at PCH on the Medical Palliative Unit is a health PEI-driven initiative to help optimize patient flow from critical care areas. The purpose of telemetry monitoring is having the ability to detect cardiac arrhythmias, monitor for effectiveness or side effects of medications, correlate signs and symptoms with cardiac rhythm and rate, detect cardiac ischemia, and to monitor and assess patients' tolerance of increased activity in a safe environment. This presentation will include a review of the anatomy and physiology of the heart and cardiac cycle. We will look at cardiac rhythms and the PCH policy and power plan. We will review telemetry and the process for telemetry at PCH. Following this presentation, you will meet with one of the clinical nurse educators and do hands-on practice and a simulation. The heart is made up of 4 chambers: the right atrium, right ventricle, left atrium, and left ventricle, and there are 4 valves: the tricuspid valve, the mitral valve, the pulmonary valve, and the aortic valve. The intra-atrial septum and the interventricular septum divide the heart into 2 pumping systems, a right heart and a left heart. Blood flows into the heart from the inferior and superior vena cava into the right atrium, through the tricuspid valve into the right ventricle. It goes through the pulmonary valve to the lungs via the pulmonary arteries for gas exchange in the lungs, and the oxygenated blood returns to the left atrium via the pulmonary veins, through the mitral valve into the left ventricle, and then to the rest of the body via the aortic valve to the aorta. This YouTube video will be attached in a separate document for your reference. Looking at the cardiac cycle, the electrical impulse will originate in the SA node and spreads through the atrial muscle along the 3 bands of tissue known as the intranodal tracts, causing atrial contraction. It reaches the AV node, where it momentarily slows before passing on to the bundle of His, and then the impulse will descend down through the bundle of His and down the right and left bundle branches. Reaching the terminal Purkinje fibers, the impulse will stimulate the ventricular myocardial cells at the Purkinje myocardial junction, and then ventricular contraction occurs. The intrinsic rate of your SA node is 60 to 100 beats per minute. If this node fails, you have a backup of the AV node, which has an intrinsic rate of 40 to 60 beats per minute. And if this fails, you have your backup, and the Purkinje fibers will fire at a rate of 20 to 40 beats per minute. As a nurse working on the medical unit, you will not be expected to interpret or analyze cardiac rhythm strips for our med-tele patients. We wanted to include a brief overview of the cardiac cycle components and potential rhythms to enhance knowledge and improve communication skills between us and our colleagues in ICU, and ultimately be able to provide the best possible patient care. This Essentials of Basic Rhythms course was developed from the Full Basic Rhythms course, which spans over 2.5 days. It is comprehensive, that it goes into more detail of rhythm analysis and management. If you're interested in taking the Full Basic Rhythms course, you can reach out to Stephanie Smith, the Clinical Nurse Educator in the ICU, at slsmith@ihis.org to find out when the next course is and how to register. The cardiac cycle consists of 1 heartbeat or 1 PQRST sequence. This sequence represents the contraction of the atria and ventricles, followed by the relaxation of the atria and ventricles. First component of the cardiac cycle is the P wave, which is caused by the depolarization of the left and right atria, A normal P wave originates in the SA node and travels through the atria, and the P wave should be before the QRS complex. Abnormal P waves may appear peaked, notched, or enlarged, and may represent atrial hypertrophy or enlargement. Could also be associated with COPD, pulmonary emboli, valve disease, or heart failure. In this strip here, you can see that the P waves are notched. So you may have a patient that goes for an echo, and if the report indicates that they have atrial hypertrophy, you could look back at the strips and see if you could find these little notches to relate back to your patient's symptoms. If the P waves are inverted, they would flip down from the isoelectric line. This may indicate retrograde or reverse conduction from the AV junction towards the atria. So the impulse would originate in that AV node, go backwards to the atria, and then kind of back through the pathway. If your P waves are looking kind of different, complex to complex, this may indicate that the impulse might be coming from different sites. So it might be a wandering pacemaker rhythm, the tissue of the atrium might be irritable, or there could be damage from around the SA node. Absent P waves may indicate conduction by route other than the SA node if they are in a junctional rhythm, for example, or AFib. If there is more than one P wave before a QRS complex, this signifies a conduction disturbance such as a second or third degree heart block. Next component that we will look at is the PR interval. This represents the time from onset of atrial depolarization to the onset of ventricular depolarization, and the normal duration is 0.12 to 0.20 seconds. If the PR interval is shorter than this normal duration, it might signify that electrical impulses are originating in ectopic sites, so not the SA node, or that the impulse goes from the atria to the ventricles through an abnormal or an accessory pathway that bypasses a part of the AV node. If the PR interval is longer than normal, this signifies that the impulse was delayed in the AV node, such as with a first-degree heart block. The QRS complex represents depolarization of the right and left ventricles, and normal duration is 0.12 seconds or less. If the QRS complex is abnormally wide or long, this may be caused by a left or right bundle branch block, premature beats before repolarization is complete, allowing depolarization of the ventricles earlier than usual, or an electrical impulse that has originated in an ectopic site in the ventricles. The P wave represents ventricular repolarization. Abnormal T waves may be abnormally tall or low, flattened, biphasic, meaning they go up and down, or inverted. Common causes of abnormal T waves include myocardial ischemia, an acute MI, pericarditis, hyperkalemia, enlargement of the ventricles, a bundle branch block, or a subarachnoid hemorrhage. ST segment represents early ventricular repolarization. We call this kind of imaginary line through the complex the isoelectric line, and normally the ST segment is flat between the QRS complex and the T wave. It is measured in comparison to the PR interval, and those analyzing the rhythms will compare if the ST segment is elevated from this isoelectric line or if it is depressed. Common causes of elevated ST segment are STEMI, acute pericarditis, hyperkalemia, or hypothermia, and common causes of depressed ST segments are MIs, non-STEMIs, hypokalemia, or digoxin toxicity. The QT interval represents the time between the onset of ventricular depolarization and the end of ventricular repolarization. The length of the QT interval normally varies with age, sex, and heart rates, and the QT interval is more prolonged with slow heart rates. There is a formula to calculate the corrected QT or the QTC, which involves a formula with the QT interval and the heart rate. Common causes of prolonged QT interval are electrolyte imbalances, bradyarrhythmias, myocardial ischemia, antiarrhythmics, or psychotropic drugs. A prolonged QT interval indicates a delay in ventricular repolarization, which lengthens the relative refractory period, which is the very vulnerable period of repolarization. This allows for more time for an ectopic focus to take control and puts the ventricles at risk for life-threatening arrhythmias like torsades. This YouTube video provides a great visual of the electrical events in the cardiac cycle, and I will leave the link attached below. The next section will provide a very brief overview of the most common rhythms we see. You always want to relate the rhythm you are seeing or being told about back to your patient, their assessment, their vital signs, and their symptoms. If you are interested in learning more in-depth information or to learn about other rhythms that we will not cover in this presentation, it is recommended that you take the full Basic Rhythms course. We will start this brief overview with our normal sinus rhythm, or the rhythm that hopefully our patients are in most of the time. Normal sinus rhythm has a rate of 60 to 100 beats per minute. The rate is regular, and there's a P for every QRS complex. Sinus tachycardia looks like normal sinus rhythm, but the rate is greater than 100 beats per minute. The rate is regular, and it often reflects overactivity of the sympathetic nervous system. It can be caused by fever, anxiety, physical activity, pain, recreational drugs, excessive alcohol, nicotine, or caffeine. And as practitioners, we typically focus on treating the underlying cause for the tachycardia. However, this can be a normal occurrence. For example, when you're exercising, your heart rate will go up, but when you're done exercising, your heart rate will come back down to your normal. Sinus tachycardia can occur as a side effect of medications, electrolyte imbalances, and hyperthyroidism, and patients may be asymptomatic, or if they have symptoms, they may be dizzy, short of breath, lightheaded, they may have palpitations, chest pain, or be syncopal. The risks of being in a sinus tachycardia and being left untreated is decreased cardiac output due to inadequate ventricular filling time. Increased oxygen demands on the heart can precipitate myocardial ischemia or infarct, depending on the health history and pre-existing conditions. And again, they could just be okay in the rhythm and tolerate it without symptoms. It is important to always assess your patient and relate findings back to them. Our ICU colleagues will be just seeing a small snapshot of our patients by interpreting the rhythms, and it is really important that we are doing thorough assessments and relating their findings back to what we're seeing with our patients. Sinus bradycardia looks like normal sinus rhythm, but the rate is less than 60 beats per minute. The rate is regular, and there is a P for every QRS complex. The underlying cause is parasympathetic or vagal dominance of the SA node. Sinus bradycardia can be a normal finding for a patient, but it could also be caused by hypoglycemia, pain, hypothermia, hypothyroidism, previous cardiac history, medications, exposure to toxins, or an MI. Patients can be asymptomatic, and if they do have symptoms, they may be syncopal, dizzy, experiencing chest pain, shortness of breath. They may have poor exercise tolerance and present with cool, clammy skin. With a sinus arrhythmia, the rate is usually 60 to 100 beats per minute. It looks like sinus with a P for every QRS, but the rate is irregular. This irregularity is caused because of the variation of vagal influence on the SA node, and you will see alternating periods of slow and fast heart rates, often related to the phases of respiration. So if you see here, the heart rate is slightly increased, and then it slows down, and then it speeds up again kind of towards the end. The heart rate will typically increase with inspiration and decrease with expiration. This can be a normal occurrence, and it often occurs in healthy individuals during sleep. Other causes may be myocarditis, an MI, digoxin toxicity, or older age. Patients may be asymptomatic, or they may be syncopal, dizzy, or have a decreased level of consciousness. Wandering atrial pacemakers, their rates are usually 60 to 100 beats per minute. The rate is irregular, and there are 3 different P wave morphologies. So the impulse arises normally from the SA node, but occasionally the pacemaker wanders from the SA node to the atria or the AV node area. So you will see this P wave is upright, this one's a little not as tall, this one's flat, this one's kind of inverted. And generally patients are asymptomatic and do not need intervention. Atrial flutter is identified by these sawtooth waves in between the QRS complexes, and depending on if there is the same number or different numbers of these sawtooth waves between complexes will determine if the rate is regular or irregular. So the number of sawtooth waves can be consistent between complexes, or they can vary. In atrial flutter, the P waves are not identifiable, and atrial flutter can be caused by older age, mitral valve disorder, ischemia, cardiomyopathy, COPD, or emphysema. Typically, patients with a lower heart rate in A flutter are asymptomatic, but as the heart rate climbs, patients can experience palpitations, shortness of breath, feelings of anxiety, weakness, angina, and syncope. Atrial fibrillation is a cardiac rhythm that most people are familiar with, and it is often included in the health histories of our patient population here on the medical unit. If the patient's rate is less than 100 beats per minute, this is considered a controlled atrial fib. However, if the rate exceeds 100 beats per minute, this is considered uncontrolled. Atrial fibrillation is an irregular rhythm, and P waves are not identifiable. Some causes include hypoxia, hypertension, CHF, coronary artery disease, valve disorders, pericarditis, hyperthyroidism, excessive alcohol or caffeine consumption. Patients can be asymptomatic, but as the heart rate is higher, they are more likely to have symptoms of palpitation, dizziness, fatigue, shortness of breath, and chest pressure or tightness. These patients are at a higher risk of thrombus and should be anticoagulated appropriately. The next couple of slides, we will focus on some of the variations of premature beats. Premature atrial contractions, or PACs, are early beats arising from an ectopic or irritable focus in the atria. There is an abnormal P wave followed by a QRS. You can see down here, down below, we have a normal beat with a PAC with an abnormal P wave coming in early. Then we have 4 normal beats and another PAC. PACs can be normal findings, and some people may not require investigations or treatment, especially if they are asymptomatic. Frequent PACs can cause palpitations or the sensation like their heart is skipping a beat. In patients with left atrial enlargement or ischemic heart disease, PACs can trigger the onset of further arrhythmias like AFib or aflutter. For example, with patients whose care involved increasing preload by aggressive fluid resuscitation, or post-op patients who have gotten a lot of fluid, their atria can be stretched, which leads to PACs. Another example are patients who have alcohol use disorder will often have dilated atrias, so we may see more PACs with the risk of flipping into an AFib with this population. Frequent or symptomatic PACs can be caused by excessive caffeine, electrolyte abnormalities, myocardial ischemia, digoxin toxicity, or anxiety. Premature ventricular contractions, or PVCs, occur when an irritable focus in the ventricles discharges before the arrival of the next anticipated impulse from the SA node. The ectopic focus stimulates the ventricles directly and produces a wide, distorted QRS complex, like you can see here. PVCs can be a normal finding and may not need investigation or treatment. It often depends on the patient's health history, the frequency of the PVCs, and if they're symptomatic. Frequent PVCs can cause palpitations or a sense of the heart skipping a beat. And similar to PACs, we would want to check peripheral pulses to determine if they are perfusing beats. In patients with underlying predispositions like an MI or ischemic heart disease, a PVC may trigger the onset of other arrhythmias like VTAC. The causes of PVCs are similar to PACs, such as electrolyte abnormalities, excessive caffeine, anxiety, myocardial ischemia, or digoxin toxicity. This slide reviews terminology that may be used to describe what is being seen and to give more information about the cardiac rhythm. So PVCs can be unifocal. They look identical kind of throughout the rhythm strip, or they can be multifocal. Multifocal PVCs originate in different parts of the ventricles. If you're having a PVC every second beat, that can be referred to as a bigeminy. Every third beat is a trigeminy, and every fourth beat is a quadgeminy. If you have two PVCs together, this is referred to as a couplet, and 3 or more PVCs in a row is considered a run of VTAC. Ventricular tachycardia, or VTAC, is one of the cardiac arrest rhythms requiring code blue. It presents like this rhythm you can see here at the bottom, often referred to as tombstoning. Ventricular tachycardia occurs when a series of 3 or more PVCs occur at a rapid rate, usually 140 to 250 beats per minute, and it occurs due to a repetitive discharge of an ectopic focus in the ventricles. Patients in VTAC can have a pulse or no pulse, and treatment is dependent on if pulse is present and the stability of the patient. Treatment of a ventricular tachycardic arrest would follow ACLS guidelines, and you can see on the pink education calendars on the desktops when the next ACLS course will be provided if this is of interest to you. Ventricular tachycardia can be caused by prolonged QT, electrolyte abnormalities, hypothermia, or structural heart issues. Ventricular fibrillation is another cardiac arrest rhythm. The patient will have no pulse, and this is the most common cause of sudden death in patients with coronary artery disease. The pattern is characterized by a rapid, repetitive series of chaotic waves originating in the ventricles. The ventricles are essentially quivering. And you can have a fine VFib like you see here, or this would be referred to as a coarse VFib. The treatment is CPR to defibrillate and then to follow ACLS protocols. And ventricular fibrillation can be caused by ischemia, hypoxia, electrolyte abnormalities, hypertrophy, or myocarditis. Asystole occurs when there is no identifiable rhythm. We want to ensure that we check the leads, as if a lead is pulled off, it can present like this flat line, and we would want to check our patient. The treatment for asystole is CPR, and then to continue following ACLS guidelines. With pulseless electrical activity, or PEA, the monitor shows an identifiable electrical rhythm, but there is no mechanical output. There is no pulse present, so the patient may look good on the cardiac monitor. It looks like they're in a sustainable rhythm, but they are pulseless. These patients require immediate CPR and activation of the code blue team. This is why the assessment piece of our med-tele patients is so important. This slide provides a brief overview of a thorough cardiovascular assessment. Historically, on the medical palliative unit, we are doing system assessments based on what the patient's admitting diagnosis is. In our satellite telemetry monitored patients, we want to ensure that we are focusing on the cardiac system and providing the patient with a thorough cardiovascular assessment. This assessment should include vital sign assessment, including temperature, heart rate, respiratory rate, blood pressure, and oxygen saturation. taking into account the patient's vital signs trends and if what you find correlates with any of the patient's presenting symptoms. When assessing the heart rate, you would want to take note if the heart rate is regular or irregular. Other aspects of inspection you would want to consider would be the color of their skin, their facial expressions, which could be indicative of what pain they are experiencing if they are diaphoretic or cyanotic, if the patient has any edema, is their chest symmetric, and noting nail bed color. There are 5 points for cardiac auscultation. The second intercostal space near the right sternal border, the second intercostal space along the left sternal border, the third intercostal space along the left sternal border, the fourth intercostal space along the left sternal border, and the fifth intercostal space to the left of the midclavicular line. On the next slide, you will see a mnemonic to correlate the 5 points for cardiac auscultation with their respective areas of the heart. As a nurse working on the satellite telemetry monitoring unit, you will not be expected to identify what classification of heart murmur you may hear, but it will be expected that you will be able to identify a normal S1, S2 with any abnormal heart sounds. During the palpation component of your assessment, you would want to ensure that you are palpating peripheral pulses bilaterally, starting with the radial and dorsalis pedis pulses, and moving inward towards the central pulses, taking note of any irregularities or pulses that are difficult to palpate. The mnemonic ape to man is an easy way to remember the 5 points for cardiac auscultation. Starting with the aortic valve at the second intercostal space, right sternal border, then the pulmonary valve at the second intercostal space, left sternal border, moving down 1 intercostal space to Erb's point, moving down 1 more intercostal space to the 4th intercostal space on the left sternal border for the tricuspid valve, and finally at the 5th intercostal space, midclavicular line on the right side would be where you would auscultate the mitral valve. Next couple of slides will review the PCH policy, use of telemetry on inpatient satellite units. To provide some background, the development of the policy has been worked on for the last couple of years, and it included doing a jurisdictional scan of what facilities across the country are doing in regards to satellite telemetry monitoring. We used the QEH's policy on satellite telemetry monitoring as our starting point, and with the information we received from our policy reviews and from speaking with nurses, educators, and leadership from across the country, we developed the policy for our facility. Drafts were reviewed by PCH Policy and Procedure Committee, the hospitalist and IM groups, ICU and medical leadership, Prince County Hospital leadership, and it is currently with the Provincial Policy Office awaiting final approval and will be posted to the MedWorks site. As indicated in the policy, care of a telemetry patient is beyond entry-level competency for RNs and LPNs and requires competency assessment. When rolling out this initiative, RNs and LPNs on the medical palliative floor were required to take this Essentials of Basic Rhythms course, review the policy, complete a learning module, and attend an in-person training session. And this will be required for all new staff going forward. If a nurse was floated to the satellite telemetry unit and had not received this competency assessment, they will continue to work within the team nursing model under the leadership of a telemetry trained nurse, ensuring that the team is aware of any limitations regarding patient care. Policy includes indications and contraindications to guide when satellite telemetry monitoring is appropriate for the patient. Indications include when monitoring a patient's response to ambulation or other ADLs is required, when we are questioning if a dysrhythmia is the cause of symptoms occurring during ADLs, monitoring the effectiveness of medications and electrolytes on the heart's electrical conduction system, and providing early detection of cardiac arrhythmias. Contraindications for satellite telemetry monitoring include the patient having frequent and increasing runs of ventricular tachycardia or prolonged sinus pauses, if the patient is having unstable bradycardic or tachycardic rhythms, if the patient is having symptomatic cardiac arrhythmias with or without hemodynamic instability, if the patient is at high risk for life-threatening cardiac arrhythmias, if the patient is experiencing significant electrolyte abnormalities with ECG changes, or if the patient is requiring critical care in continuous or intermittent IV infusions to maintain stability. If patients are experiencing anything from the list of contraindications, they should be admitted to a higher care area on a bedside monitor. It is important to note that there are no changes being made to the interventions we can provide on the medical unit. Therefore, you will need to refer to this IV manual for guidance on what medications can be administered on the floor or when the patient care would have to be escalated to receive appropriate interventions. And for clarification, cardiac monitoring is not synonymous with satellite telemetry monitoring. Cardiac monitoring would include being on a bedside monitor with a nurse trained in cardiac rhythm analysis as their primary nurse. The MRP must give an order to initiate, temporarily suspend, or discontinue satellite telemetry monitoring, and the need for telemetry monitoring must be assessed daily by the MRP. If the patient is on satellite telemetry monitoring for greater than 72 hours, it is recommended that an IM consult be considered. Appendix D of the policy gives indications and timeframes for monitoring as a reference for the MRP. And as part of the power plan, activity levels will be activity as tolerated, pre-selected. If the MRP wants to start cardiac activity levels, nursing can increase the level daily if pain-free. Section of the presentation will include a review of the roles and responsibilities. As the medical nurse or the primary nurse for the med-tele patient, the expectation is that when a satellite telemetry monitoring order is given by the MRP, that we notify the ICU regarding the order and obtain the equipment from the medical med room. We will photocopy the front page of our Cardex and complete the satellite unit telemetry Cardex and send both documents to ICU. We will be responsible for providing patient education regarding the device, symptom reporting, and signal reception. And we will prepare the patient's skin and apply the electrodes, ensuring that the patient has patent IV access. Every 24 hours, there will be a Cerner task fire to change the telemetry device batteries and electrodes, and the medical nurse will carry a designated phone to respond appropriately to calls from the ICU RN monitoring the patient. The medical nurse will communicate with the ICU nurse at least once per shift to receive rhythm interpretation, and they will be responsible for updating the ICU RN with any status change, med adjustments, or plans for the patients. The medical nurse will complete thorough cardiovascular assessments and will be responsible for notifying the MRP of any significant change in the patient's status. The clinical lead or the primary medical nurse will also review with the MRP daily the need for continuation of telemetry monitoring. The ICU nurse will be responsible for admitting the patient to the central monitor and receiving report from the medical nurse. The ICU nurse will contact the medical nurse every shift and provide rhythm analysis. The ICU nurse is responsible for recording and analyzing telemetry strip on admission at the beginning of each shift and when any rhythm changes are noted. The ICU nurse will report and identify the significance of any rhythm changes and respond to potentially lethal rhythm changes by immediately notifying the medical nurse to go assess the patient, and the ICU nurse will be available to respond via rapid response or code blue if the situation requires. The ICU nurse will discharge the patient from the central monitor when telemetry has been discontinued by the MRP. The expectation for our physicians would be that they place the order for satellite telemetry monitoring by using the telemetry monitoring in an inpatient satellite unit power plan, that they would review strips and telemetry monitoring data from the previous 24 hours and document in progress notes daily, that they will direct patient care and treatment in response to ECG findings, consulting IM when needed, that they will review the need for telemetry monitoring daily and write orders to suspend or discontinue satellite telemetry monitoring as appropriate. The next few slides will review the the power plan and order set developed for the use of satellite telemetry monitoring on an inpatient unit. These are all the options that will be available in the power plan. The admit to and transfer to orders will be important for data collection and to see how often the service is used, as well as thinking ahead to the future when we're looking at resources that will need to be increased. There will be some pre-selected notify physician if, as well as the free text orders to nurse will be pre-selected as well. As previously mentioned, the activity level will be pre-selected as activity is tolerated, but the physician can order cardiac activity levels if they see fit. The power plan also gives reminder for resuscitation status to be ordered if not previously discussed with the patient, as well as some options for stat and daily blood work. There are options for diagnostic imaging to be selected by the physician. Orders for vital signs will be QID and PRN and may be required to be increased or decreased depending on the patient's status. It will be important for the MRP to order satellite telemetry monitoring using the power plan because it also includes nurses' tasks to change the telemetry batteries and ECG electrodes every 24 hours. For diagnostic tests, the ECG stat upon the initiation of telemetry monitoring will be pre-ticked, as well as the place order for ECG if chest pain rhythm changes or on the advice of the telemetry monitoring ICU nurse. In regards to continuous infusions, the order will be pre-ticked to insert a saline lock, to maintain that saline lock as per policy, and to remind the nurse to ensure that the patient has patent IV access at all times while on telemetry monitoring. Although there are two cardiac monitoring modalities, either a hardwired bedside device or a wireless device, they both provide a continuous ECG rhythm obtained using electrodes and leads. A telemetry device, which you will see here down on the right, is a small portable cardiac monitor that allows the patient to ambulate while monitoring their cardiac rhythm, rate, and to detect any arrhythmias. The monitoring can be done directly on the telemetry device, projected to a bedside monitor, or via a remote monitoring system, which will be in effect at the PCH on the satellite monitoring unit, the medical palliative unit. Applying telemetry on your patient. Step 1, explain to the patient the indication for cardiac monitor and orientate the patient to the equipment. Step 2, perform hand hygiene. Step 3, expose the patient's chest. Step 4, clean and prepare the chest area for electrode placement. Wash with soap and water and dry well to improve electrode adherence. Clip excessive hair rather than shave if needed, and use gauze to remove dead skin cells which interfere with impulse transmission. Step 5, apply electrodes, avoiding bony prominences, skin folds, areas with scar tissue or skin lesions. Change electrodes every 24 hours and as needed to assess skin integrity and to decrease the number of electrode-related technical alarms. Step 6, attach cable leads to electrodes. Step 7, provide the patient with the telemetry education pamphlet. Moving on, we will look at the electrode placement. So the white electrode is placed in the right clavicular hollow, second intercostal space, right clavicular line. The black electrode is placed in the left clavicular hollow, second intercostal space, left mid-clavicular line. The green electrode is placed below the lower edge of the rib cage, right side. And the red electrode is placed below the lower edge of the rib cage on the left side. And the brown electrode is placed at the fourth intercostal space, right sternal border. This is the memory trick to recall the 5-lead ECG placement. We think of white on the right, and then clouds over grass, so white over green.
Smoke, the black over red, so smoke over fire, and I heart chocolate, chocolate by the heart. The next few slides will identify some of the minor changes that will take place in the process depending on when the patient is ordered satellite telemetry monitoring and where they are being held in hospital. If there is a current medical patient admitted to the medical floor and they are subsequently ordered satellite telemetry monitoring, we will get the MRP to order the power plan, inquire if the MRP wants the baseline ECG done, in saying that they might have already had one recently that prompted the telemetry order, so that might not be necessary. The medical staff will call ICU and notify them of the order and give a brief report, sending the cardexes to ICU. Equipment will be obtained, the patient prepped and electrodes applied, and then the patient and family will receive education, including the education pamphlet. If a patient is transferred to medical out of ICU if they've been declassed, or if the patient is admitted from the ER with telemetry monitoring, as the medical floor nurse, we will want to ensure that the power plan is ordered, making sure that we have our tasks firing appropriately. We will ensure that the ICU nursing staff are aware that the patient has been moved to medical and what room they're in. And then we always want to verify lead placement. Although the patient may be coming from a critical care area, nurses are human, and we want to ensure that the lead placements are in the correct position. This slide reviews a few bits of information that didn't really fit anywhere else in the presentation, but that we wanted to include for staff. So although med-tele patients will be considered priority for admission or transfer to the medical unit, ultimately it will be up to the nursing supervisor's discretion as they know what's going on in the building as a whole and where the resources would be better allocated. A reminder that the rapid response team and code blue team are available in situations requiring assistance. If all 4 telepacks are in use and another patient is in need, it will be up to the MRP to discuss with the other MRPs which patient needs the monitoring most. We only have 4 telepacks for the medical unit, and we can't just bump up to 6 or 7. It includes having the licensing on the central monitor and ICU, and our max is 4. And then for those staff that are interested in advancing their knowledge and understanding, there is the full basic rhythms course offered by Stephanie Smith, the ICU Clinical Educator. And her contact email is slsmith@ihis.org, and you can contact her to find out when the next course is going to be held. The last few slides are going to review what the iView charting for the telemetry patients will look like. So when the telemetry band is added to your iView, there's 2 sections, the telemetry care, which is mostly where the medical nurses will be charting, and then the telemetry rhythm analysis, which will be primarily for the ICU nurses doing the rhythm interpretation. So under telemetry care, the medical nurses will chart when the ECG electrodes were changed. ECG electrode interventions include a skin assessment, so that will be charted there. We'll double check that the telemetry box number matches the previous shifts, and this correlates to where they fit on the central monitor screen in ICU. The medical nurse will chart that the telemetry batteries were changed, and then this kind of shows what it will look like after the medical nurse provides their documentation. For the ICU nurses, they will do their charting under the telemetry rhythm analysis component of the telemetry band, and this information is accessible for the medical nurses to review as well. So the ICU nurses will chart which lead they were looking at and the cardiac rhythm. They will do their measurements for the rhythm and identify any ectopic beats, frequencies, and what they look like. This information will be relayed to the medical nurse, and then the physician will be expected to either review the telemetry rhythm analysis portion on iView or go to the ICU and review the strips in person. At the time of this presentation, October 2025, surgical telemetry patients will not be accepted to the satellite telemetry monitoring unit on the medical floor. This means that sick pre-op or post-op patients will continue to go to the ICU for telemetry monitoring. If the surgeon wants to admit the patient solely for telemetry monitoring and the patient does not require critical care admission, despite being admitted into the ICU, the patient will have to meet the inclusion criteria outlined in the policy for satellite telemetry monitoring. To arrange the hands-on portion of the satellite telemetry monitoring training, please contact your clinical educator. This concludes the presentation. Thank you for watching.